of certain levels of skill, those may actually make more sense that we do, and these other things are done. And it depends on your situation. Again, we're not all the same. I end up doing most pretty much of everything. So the expertise, best evidence, and then I always like to throw this out there. Remember that it matters what our patients think, because our patients have a buy-in to this. And you know, I don't want to use the term placebo or reverse placebo. Is if they don't do it, they don't want to do it, then they're not going to be compliant, and that's a problem. So the physical agents are not designed to, take over per se, but they're designed to complement. I still recommend that clinicians, when you think about adding a new procedure, whatever it is and how you talk about it is still important in the context of who you are and what it is that you offer, because that's actually what separates us, is kind of getting to that level, how we use these tools, and in the context of your overall care plan. So, here's a classic, right? And if you're in outpatient physical therapy or chiropractic, your number one ICD-10 code is low back pain. That's what the literature shows. Same population, same group. It's usually middle-aged people, constant, more than 6 months. It's like, why did you come in now? And it's like, well, they've lost the ability to do X, Y, Z. And so it's classic, and we see that a lot. So our job is to try and figure out, what exactly should we do with these people. So we first take in the complaint, and this is, as we all know, have been taught, 80% of our diagnosis comes from the history. So really important that we take that in. What's cool, and I've had a lot of discussions around this lately, is when we look at the addition or the changes over in the ICD classification, is we're adding more and more of these labels that are not just diagnostic, right? I use the example of a study because I do a lot of decompression stuff. Ghost et al. In 1998, in there it was a